everyone.
So here is our specimen, and the talk today is going to be on the placenta. So first off, it's important to note that we do not receive all placentas. That would be a ton of placentas for us to gross. So it's important to note that the pathology department only receives placentas when there is an abnormality relating to either the fetus or mother or for multiple gestations. So here's just a list of some of the reasons why we may receive placenta specimens in the lab. So for example, maybe chorioamnionitis, intrauterine growth restriction, maternal preeclampsia, and so on. So our specimen is a singleton placenta. So that includes the placental disc, which is shown here, the umbilical cord, which is here, and then the membranes, which you can see here. So now we're going to go in and talk about each one of these components in a lot more detail. And we'll start with talking about the placental disc. So normally the placental disc, the average size at term would be about 22 centimeters in diameter and about 2 to 2.5 centimeters in thickness and 470 grams trimmed. So for our specimen today, our total measurement is about 18, 19, and then about by 15. So this one's a bit smaller than the average term placenta, which makes sense because the clinical history for this one is intrauterine growth restriction. And now I'm going to put up our first polling question. So what are the 3 layers of the placental disc going from the fetal surface to the maternal surface? Okay, so I'm going to end the polling there and share the results. So yes, the correct answer is C. So going from the fetal surface to the maternal surface, it goes amnion, then chorion, and then decidua. And you can see that in the diagram there with those blue circles indicating those different layers. So the placental disc can come in multiple different shapes. It can be ovoid, round, irregular, bilobed, could contain an accessory lobe, or it can come fragmented. So there's an example of a ovoid placenta on the PowerPoint screen there. And then the second image there is showing an example of a fragmented placenta. For this specimen here that we have out today, this one would be another example of a ovoid placental disc. And now I'm going to put up our next polling question. So which of the following is false regarding succenturiate placenta? And I'm going to end the polling there and share the results. So it looks like there was a pretty close tie between C and D. The correct answer is actually D. So we'll move on and show you a diagram here, just showing the differences between a bilobe versus a succenturiate placenta. A bilobe placenta contains 2 lobes of equal size, and these ones are attached by either membranes, vessels, or the placental disc. The succenturiate, also known as an accessory lobe, contains a primary disc plus smaller lobes, and this can be 1 smaller lobe or multiple smaller lobes. And these lobes are connected to the primary disc by either membranes or vessels. So they are not connected to the main disc by the placental parenchyma. Now we'll talk about the fetal surface. So the fetal surface should usually be a pale blue, smooth, and shiny. So you can see with ours, it looks pretty normal here. It's this nice pale blue, it's pretty shiny and smooth. we do see a little bit of these white plaques here. So these white plaque-like areas represent subchorionic fibrin deposits. And another abnormality that we can get with the fetal surface would be cysts. And these cysts usually cause no complications with the pregnancy if they're small. However, if they're very large, they can cause intrauterine growth restriction. Now we'll talk about the maternal surface. So that would be this surface here. So usually this should be a gray, brown color, and it should be rubbery. And we also want to talk about the intactness of the maternal surface. So whether it's intact or not. If it's not intact, that may indicate that there could be retained placenta inside the mom. So for our specimen out today, it looks like it's intact. These areas where it looks a little bit irregular here is just from artifact from formalin fixation, where the placenta was kind of curled like this, and I had to open it just to demonstrate that maternal surface. So another abnormality that we could get with the maternal surface would be an adherent blood clot. And so if we get blood clot like this, we'll want to measure the entire blood clot in 3 dimensions, and then as well give the percentage of placenta parenchyma involved by this blood clot. And this blood clot may represent placental abruption, which is a serious condition in which the placenta separates from the wall of the uterus before birth. Now we'll talk about the umbilical cord, which is here. So the umbilical cord contains one vein, which carries oxygenated, nutrient-rich blood to the fetus, 2 arteries that carry deoxygenated, nutrient-depleted blood away from the fetus, and then these vessels are surrounded by Wharton's jelly. So on cross-section, this can look like a smiley face. The average length of the umbilical cord is about 55 to 60 centimeters, and then the diameter is usually about 2 to 2.5 centimeters in diameter at term. Occasionally, we can get a 2-vessel cord, so 1 vein and 1 artery, and this can sometimes be related to fetal anomalies, specifically those relating to fetal kidney or heart anomalies, and they can also be associated with a higher incidence of filamentous cord insertion. And we'll talk about this cord insertion on our next slide here. So the umbilical cord insertion can either be central, so that would be right in the center, which looks to be the case for this placenta out for today. It looks like it's right in the center. It can be eccentric, so that would be a little off center, so maybe around here. It could be marginal insertion, so that would be where it's less than 2 centimeters from the placental disc edge. And that's shown in the picture on the PowerPoint screen there on the left-hand side. Or it can be filamentous insertion, which is shown on the right-hand image there. So filamentous insertion is when it inserts onto the membranes, and these vessels are exposed to then trauma or rupture, and this can lead to fetal morbidity or mortality. This is also associated with twin gestations, congenital malformations, maternal smoking, and a single umbilical artery, like we mentioned on the previous slide. And this occurs in about 1% of placentas. So now we'll talk about coiling, and I'll put up our next polling question. So what is the normal amount of coils an umbilical cord should have for every 5 centimeters? Okay, so I'm going to stop the polling there and share the results with you. So the correct answer is B, and it looks like most people did get it correct. It was pretty close though with A. So the correct number should be 1 to 2 per every 5 centimeters. And so this is a picture here. just showing hypercoiling. So hypercoiling is when there are more than 2 coils per 5 centimeters, and the number of coils is directly related to fetal movement. And this can cause serious complications like fetal growth restriction or even death. So another thing that we can get with the umbilical cord is knots. So the image on the left-hand side there is showing an example of a false knot. A false knot is an extra looping of blood vessels inside the Wharton's jelly, and they have no clinical significance. For true knots, which is shown on the right-hand image, that one can lead to fetal hypoxia, neurologic impairment, or fetal demise. So now we'll talk about the membranes. So we want to evaluate the color and opacity of the membranes. So the normal membrane should be pale tan and translucent, like the ones that we see here with our specimen. If you see green stained membranes, that could indicate meconium. Brown stained could be hemosiderin. And then if you see opaque membranes, like the one shown on the image in the PowerPoint slide there, that one can represent chorioamnionitis. So now we'll talk about membrane insertion, and we'll put up our next polling question. So what is it called when the membranes insert inside the edge of the placental disc and fold back onto themselves? Okay, I'm going to stop the polling there and share the results with you guys. So it looks like there's a tie between circummarginate and circumvallate. So we'll go through the differences between these two in our slide here. So the image on the left-hand side there is showing what circumvallate looks like. So circumvallate is when those membranes are inserting inward on the placental disc and then they fold back onto themselves. Versus circummarginate, which is shown on the right-hand image there, that's when the membranes insert towards the center of the placental disc, but then they do not fold back onto themselves. So they insert flat onto the placental disc. So here's just another diagram really depicting those differences. So the picture at the top is showing normal insertion, also known as marginal insertion. So that's when the membranes insert directly onto the edge of the placental disc. So that's the case is for this specimen. So you can see that the membranes are inserting directly onto the edge of the placental disc all the way around. So for circummarginate, that's when the membranes again insert inward on the placental disc, and their insertion is very smooth. And then circumvallate is when those membranes insert inward on the placental disc, but it forms more of a ridge because those membranes are folded onto themselves. So I like to think of it as circumvallate, that a valley is forming. Now we'll talk about the differences between amnion nodosum and squamous metaplasia, and I'll put up our next polling question for this one. So which of the following is true in regards to squamous metaplasia of the placenta? Okay, so I'm going to stop the polling there and share the results with you guys. So yes, the correct answer is B. It is white nodules that do not come off the amniotic surface. So now we'll just talk about the differences between these two. So amnion nodosum is multiple white, firm, well-circumscribed nodules on the amniotic surface, and they are composed of squamous cells from fetal skin, and they're most commonly associated with severe or prolonged oligohydramnios. Squamous metaplasia mimics amnion nodosum, on gross examination, it can be differentiated from amnion nodosum by the fact that squamous metaplasia cannot be scraped off the fetal surface versus amnion nodosum can. Another difference is that amnion nodosum can occur anywhere on the amniotic surface versus squamous metaplasia most commonly occurs at the site of umbilical cord insertion. So that would be around this area. Squamous metaplasia also has no clinical significance. So in relation to this image here, I'll put up our next polling question. So what gross finding is shown in this image? Okay, so I'm going to stop the polling there and share the results. Good job, most people got it correct. It is a yolk sac remnant. So the yolk sac remnant is that pale yellow nodule there that's seen in the membranes. So this is something that you may come across when you're grossing placentas, and it's just a good idea to know what this is. There is no clinical significance, however. So now we'll talk about the placental parenchyma. So that would be when we slice through and what we see on the inside here. So the placental parenchyma should usually be a red-brown color, and then it should be rubbery or spongy in texture. When sectioning the placenta, we may find some lesions that look like this. So these would be examples of infarcts. So the one on the left-hand side there is showing an example of an older infarct. And then the one on the right-hand side there that's more hemorrhagic, that would be showing an example of a newer infarct. So when we're grossing these, we would just want to indicate where the infarcts are and the percentage of them. And I'll put up our next polling question in relationship to this. So which of the following gross findings would be the most clinically significant in a term placenta? Okay, so I'm going to stop the polling there and share the results. Yes, so great job, everyone. The correct answer is C. So it would be multiple infarcts that are occupying 30% of the disc and that are located centrally. So the amount, so the percentage of disc involved with the infarcts, so the higher the percentage, the more clinically significant that would be. And then as well, if they're located centrally, that's also more clinically significant than if they were located peripherally. Usually the edges of the placental disc are already a little bit more poorly perfused than the center of the disc. And this can then lead to growth restrictions. And if there's extensive involvement, this can actually lead to fetal death. So it is really important, like I mentioned, that we want to document the percentage of these infarcts and then as well where their location primarily is. So another finding that we may come across when we're sectioning through placentas is a chorangioma. So this is the most common placenta tumor. However, it's still only found in about 0.5 to 1% of all placentas. So it is still very rare. And for gross appearance, it looks usually like a single or multiple well-circumscribed spherical or ovoid masses. And you can see that with the orange arrow there. So this one looks very hemorrhagic and very well circumscribed versus what we saw with the infarcts in the previous slide. That was a little bit more of a triangular shaped or irregular shaped versus this one is very well circumscribed. So now we'll talk about abnormal placentation. So placenta previa. So that's when the placenta inserts or implants onto the lower uterine segment. And this can partly or completely occlude the internal os. This can cause late vaginal bleeding and emergent cesarean delivery. For gross features that we want to be looking out for this would be a marginal hematoma. Also, the membrane rupture site may be closer to the disc edge. Invasive placenta is the abnormal adherence of the placenta to the uterine wall. And I'll put up our next polling question here. What is the classification for when villi invades into the myometrium but does not perforate the serosa? Okay, so I'm going to end the polling there and share the results with you guys. Great job. It is placenta increta. And now we'll talk about those differences. So for invasive placenta, there's 3 different types. So there's accreta, increta, and percreta. So accreta is when the placenta adheres onto the myometrium. Increta is when the placenta invades into the myometrium. And then percreta is when it perforates. So I like to remember it as matching the first letter. So the A would match with the A, and the I, and the P with the P. So here's just a diagram here just showing what the normal placenta insertion looks like, where it's attaching to the endometrium, and then what accreta looks like, where it's adhering onto the myometrium, and then increta when it's invading into the myometrium, and then percreta when it's perforating through. And I'll put up our next polling question. So which of the following is not a risk factor for invasive placenta? Okay, so I'll end the polling there and share the results with you all. So that is correct. A is the correct answer. Chorioamnionitis is not a risk factor for invasive placenta. So previous cesarean sections are an increased risk factor. So the greater the number of previous cesarean sections, the greater the risk for accreta. As well, placenta previa is also a risk factor. And then Asherman syndrome is also a risk factor. So that is an acquired condition where scar tissue forms inside the uterus. And the most common cause of this is several D&C procedures. So now I actually have an example of a surgical specimen that we got out for an invasive placenta. So you can see, I'll just orient you all. So the uterus, and then you can see the cervical resection site, and then the cesarean site. And then inside you can see the placenta there. So here are a few cross sections of what it looked like. So on the top there, you can see the placenta. And then the bottom is the uterus. And then that blue arrow there is showing the interface between the placenta and the uterus. So this one on clinical history was out for placenta accreta. And you can see on that left-hand image there that the interface is very smooth, versus on the right-hand image, you can see that it's a bit more irregular. And so right where that yellow arrow there is, that's actually showing placenta increta. So it's actually invading into the myometrium versus just adhering to the myometrium. So it's really important when we get specimens like this that we're serially sectioning throughout the entire specimen so that we identify any of these small focuses of placenta increta. So now we'll go on into sectioning placentas. So we'll want to take one section of the membrane roll. And I like to do this by cutting out a strip of the membranes with scissors. And then I would roll the membranes up with forceps, and I like to keep it attached to the edge of the placental disc. This just allows for a better anchoring point when I'm making that membrane roll. As well, I like to get the point of rupture in my sections because that's usually where the membranes are the weakest. So if there was any chorioamnionitis or anything, that would be a good area to sample. I would also be wanting to give 2 sections of the umbilical cord. So I'd give one section that is about 1 to 2 centimeters from the insertion site, so about here. And then I also give one section that's closer to where the fetus would have been, so more along here. I'd give 2 full thickness sections of the placental disc showing both the fetal surface and the maternal surface. And then I'd give any additional sections of any abnormalities or lesions identified. So here's just some examples of grossing a placenta. So the image on the left-hand side there is just showing a sliced up placenta. So it's really important that we serially section throughout the entire specimen because you can miss incidental findings if you don't cut through every aspect of the placenta. Another good tip would be to cut the placenta going from the fetal surface to the maternal surface. This way you can just see that amnion better so that you don't lose it in your sectioning. So it's really important when you're submitting your sections that you get that amnion in there. And sometimes if you're sectioning with the fetal surface down and the maternal surface up, that amnion can actually rub off on whatever surface you're cutting the specimen on. So if it's paper towel or something. And then the image on the upper right-hand side is just showing an example of a full thickness section. So the upper portion there would be the fetal surface, and then the lower side would be the maternal surface. And then the last image there is just showing an example of a membrane roll. So another tip for cutting membrane rolls is to make sure you have a sharp, fresh blade every time that you make a new membrane roll. That will just avoid any pulling of the tissue and will help prevent the membrane roll from all falling apart. So here's a sample gross description of a placenta that I grossed earlier this year. So I'd want to say what the specimen consists of. So a singleton placenta. I give the weight and I want to give the weight trimmed. So I'd take off the umbilical cord and the membranes. And then I'd give the disc measurements in 3 dimensions. And then I'd say that there are attached membranes, a portion of the umbilical cord, and I'd give that in length and diameter. And then for this example, then I went in to talk about the membrane insertion. So this one was circummarginate on half the placental disc and then marginal for the remaining half. So if you have some sort of insertion that's different than marginal, it's important to indicate how much of the placental disc is involved with that abnormal insertion. And then I'd also say that the membranes are pale tan and translucent. My next paragraph will be talking about the umbilical cord. So I'll say the umbilical cord insertion is eccentric and 5.0 centimeters from the disc edge. The cord contains 3 vessels with normal twisting. And then my last paragraph there will be talking about the placental disc itself. So I would say that the disc is round shaped. The fetal surface is pale blue, smooth, and shiny. The maternal surface is gray-brown and intact. The placental body is red-brown and rubbery with no masses grossly identified. My section code for this will be representative sections. And my first cassette will be my membrane roll and umbilical cord at the fetal aspect. My second cassette will be my umbilical cord at the maternal aspect. Sorry, this is the fetal aspect, and then this will be the maternal aspect. And then the placental disc, 2 full thickness sections. So now we're going to talk about twin placentas. So for twin placentas, you can get dichorionic, diamnionic, and this would be when there are 2 separate placental discs and 2 separate amniotic sacs. And these can either come separate or fused. So if they're separate, they would look like 2 individual singleton placentas just like this. If they were fused, they would have a dividing membrane in between the 2. And this membrane would be 2 layers of amnion and 2 layers of fused chorion. And these membranes are usually thick and opaque. Another type of twin placenta is monochorionic diamnionic. So this would be when there is 1 placental disc and 2 amniotic sacs. And this one also has a dividing membrane, which consists of 2 layers of amnion. And these dividing membranes are usually translucent. And then the last type of twin placenta is a monochorionic, monoamnionic. So this one would have no dividing membrane. And so I'll put up our next polling question here in relationship to this image. So what type of twin placenta is shown in this image? Okay, so I'm going to end the polling there and share the results. So most people said that it was separate. However, the correct answer is actually C. So it is di-di fused. So you can see that there are two placental discs, and then you can see that they are actually combined together by those membranes there. So these ones would be fused. This next image here is showing an example of monodi. So this is showing one placental disc, two amniotic sacs, and then a thin translucent dividing membrane. The last image here is showing an example of mono-mono. So this would be one placental disc and then one amniotic sac. And so now we'll go through sectioning twin placentas. So we'll do one section of the dividing membrane, and we want to include a portion of each twin's membranes as well. So it would come out to be more of a T-shaped tissue sample. And then we'll also be wanting to give one section of membrane roll from each half. And then we'll be doing the two sections of umbilical cord for each half. And again, being that one section from the 1 to 2 centimeters insertion site, and then one section near the fetus. We'll do two full thickness sections of the placental disc from each half, and then we'll submit any additional lesions or any abnormalities that we find grossly. And here is a sample gross description of a twin placenta. So I'd want to say what the specimen consists of. So a twin placenta, I'd say that the specimen has been oriented as per requisition with single clamp twin A and double clamp twin B. If the requisition has no orientation given, then you will arbitrarily designate one half as twin A and one half as twin B. Then I'll talk about what the specimen includes. So the specimen includes the placental disc, and I'll give that in weight again, trimmed, and then 3 dimensions with attached membranes, and then the 2 portions of umbilical cord. So I separate that out as twin A and twin B. My next line, I'll want to discuss the dividing membrane, so what it looks like, so pale tan and translucent. And then I also want to indicate how much space twin A versus twin B is occupying on the placental disc. And this will be given in %. My main findings of my gross description, I'm going to break that down into twin A and twin B, just to keep it in a very organized fashion. So for twin A, I'd say I'd start with talking about the membranes, and I'd say the membrane insertion is marginal. The membranes are pale tan and translucent. And then I'd go in to talk about the umbilical cord. So the umbilical cord insertion is eccentric and blank centimeters from the disc edge. The cord contains 3 vessels with normal twisting. And then I talk about the placental disc. So the placental disc is round shaped. The fetal surface is pale blue, smooth, and shiny. The maternal surface is gray, brown, and intact. The placental body is red, brown, and rubbery with no masses grossly identified. And then I do the exact same for twin B and talk about all the findings on that half of the placenta. For my section code, it will be again representative sections. My first cassette will be the dividing membrane. My second cassette will be twin A with the membrane roll and umbilical cord at the fetal aspect. And then my cassette C will be my twin A umbilical cord at maternal aspect. And then 4 to 5 will be the twin A placental disc full thickness sections. 6 will be twin B, and it will be the membrane roll and umbilical cord at fetal aspect. And then 7 will be twin B umbilical cord at maternal aspect. And then 8 and 9 will be twin B placental disc full thickness sections again. So that is the end of today's talk. Thank you all for attending, and I hope to see you again next month.